gives me now the pleasure to invite our next speaker to the podium, Dr. Chiawei Teo, who will talk about a journey through a lifetime of aHUS. Dr. Teo is a pediatric nephrologist and director of the kidney transplant program at the Hospital for Sick Children. He's an associate professor in the Department of Pediatrics at that university. He's also the past chair of the pediatric group of the Canadian Society of Transplantation. Dr. Teo completed his specialist training at the Royal College of Physicians of Ireland before completing a pediatric nephrology and kidney transplant fellowship in Canada, during which he completed a Master of Science degree at the University of Toronto, studying the role of complement in CNI-induced endothelial cell toxicity slash TMA, which you have seen the results of in summary this morning on one of the slides. Dr. Teo's clinical and research interests focus on complement-mediated kidney diseases and injury, especially in transplantation, and improving long-term outcomes in pediatric kidney transplantation. Chiawei.
Thanks for that introduction, Christoph. I've been in Canada now for more than 10 years. I've been working with Christoph on this, but it's really a privilege for me to be able to join all of you with aHUS Canada for the first time. And it reminded me and maybe regenerated some of my enthusiasm and of why I got into this in the first place. I hear some of your personal stories, and talking to Karen reminded me of this story as well. But I get that all of you here are either patients or caregivers who have been affected by atypical aHUS. I think my personal story with regards to atypical aHUS is from the clinician side. So I hope it comes through a little bit in the talk as well. I think...
Dr. Teo, can I interrupt you a minute? Can you speak more into the microphone?
Oh, I'm sorry.
Thank you.
What inspired me in the first place was the privilege that I had to meet some of these patients with atypical aHUS during the formative years of my medical school and training. And it was during the time when there was no anti-complement treatment. I had the first-hand opportunity to witness how devastating disease like atypical aHUS could be. And then I had the opportunity to also see how the advent of anti-complement therapy, understanding the underlying disease mechanism could go a long way to help improve those outcomes. And I hope, where this talk goes is painting a bit of a more hopeful picture, although there's a lot of work still to be done. So when I got the invite to give this talk from Tom, I was thinking, how could I possibly give a talk about living with the chronic trauma of atypical aHUS to a group like you guys with lived experience? So I hope you would indulge me that what I would try to do is to describe this journey from a clinician's perspective. And what I was intending to do is to complement, no pun intended, all the previous speakers who eloquently described the disease mechanism, treatments, and some of the historical context, and try to put it all together in a few patient stories that I've had the opportunity and privilege to be part of. We will, through that journey, go through a bit of the clinical course of a patient with atypical aHUS, and it spans the pre-anti-complement therapy towards what we consider now post-anti-complement therapy. And these are my personal and professional reflections. And with that, we will begin. So I was going to introduce you to one of the patients whom I had the opportunity to look after very early on in my career. This was an 8-year-old child at presentation, presented with headaches, some nosebleeds, and a particular rash. And particular rash is a rash that has very small pinpoint red dots on your skin that does not blanch. And it's due to having low platelets and sort of almost bleeding into the small capillaries around your skin. This child has no diarrhea, and there was some microscopic blood in the urine and a lot of protein in the urine. And this is a very quick summary, but you would probably recognize that there was the hallmarks of thrombotic and microangiopathy and aHUS, where there was hemoglobin, blood cells lysing, and that's why you see the hemoglobin being low and the LDH being high. There was also platelets causing clots and being consumed, and so platelets were low. And then there was acute kidney injury with a high urea and a high creatinine. This patient went on to have a kidney biopsy, which showed typical features of what we would consider thrombotic microangiopathy, which I'll show you some representative slides on in the next few slides. So before I begin, I was going to go back a little bit to use a bit of this historical context to almost lay the scene for our discussion. aHUS as an entity, as a syndrome, was really originally described in the 1950s by Gasser et al. And for the longest time, there was not much further development until the 1980s when Pharmacie, who, fun fact, is a physician and clinician here in Toronto at SickKids, who described and discovered, I guess, what we now know as the Shiga toxin, which is associated with this E. coli infection causing Shiga toxin aHUS. And then for a little while in the kind of late 90s to early 2000s, our knowledge and our description of this condition was very clinical based. So what you can see at the bottom is how we used to think about this dichotomized way of patients presenting with this condition, like Christoph had kind of alluded to at the beginning. So we used to think of patients of having diarrhea positive aHUS, and they're likely Shiga toxin aHUS patients. And then there are diarrhea negative aHUS patients. And then there are patients with TTP, which presents with more of CNS, cerebral, brain kind of symptoms. And then after that, the field kind of started progressing towards trying to define this syndrome and this varied varied causes of this similar presentation based on underlying disease mechanisms. And that was when, I guess, the term atypical aHUS started to be used. Again, initially, tended to be all-encompassing of every aHUS that is not due to Shiga toxin aHUS. But over time, it's been really more evolving to what we would currently consider as the atypical aHUS that we talk about as complement-mediated and complement-associated atypical aHUS. And on top here, what I'm trying to depict is also a bit of the timeline of this, our understanding and the discovery of the various underlying complement genetic variants that patients might carry that contribute to the risk of developing atypical aHUS. And going back a bit to my personal story, here I was starting my medical school career in the early 2000s, and then progressing to residency training, subspecialty training, and somewhere in between, which Valentina spoke about in 2011 to 2013, was kind of when anti-complement therapy started to be proven to be effective and helpful for patients. And that was where, that was what solidified my interest and motivation in pursuing nephrology and this area of study from a personal perspective. So we currently know that there's really a wide disease spectrum with patients who can present with very similar features that we call thrombotic microangiopathy. And atypical HUS, which is due to complement disease or an factor H autoantibody, is but as one of those potential causes of TMA. And broadly thinking, I think Christoph has alluded to this morning as well. We can think about TMA as those who have primary TMA, and in primary TMA, you could have a hereditary form, a genetic form. So those with underlying complement genetic variants that predispose to complement dysregulation, or potentially a bit of an acquired form that you develop these autoantibodies that prevent your complement system from regulating itself very well. And then there are other kind of secondary forms of TMA, which you would have heard of related to pregnancy, medications, certain types of infections, et cetera, et cetera.
When you say medications are secondary to infections, this has nothing to do with genetics. Like genetics is not involved with us.
Very good question. I think, most of the time we think about it as potentially patients only having one type of the condition. But one of the cases that I was going to share would hopefully illustrate that you could have an underlying complement genetic variant that would have predisposed you to develop this condition. And then the condition that triggers that all off is an infection. And an infection like Shiga toxin HUS could be that trigger that triggers the HUS. So there may be some overlap in this. Okay. And so I guess for the rest of this talk, I just want to be clear, I think most of the time I will be referring to the complement-mediated type of atypical HUS. And so, how do patients usually get recognized and how do they present? The hallmark of, I guess, this abnormality is this feature of thrombotic microangiopathy that we can detect on blood work. And it's that platelets being low, leading to hemoglobin and red cells being lysed and leading to anemia, and all that leading to acute kidney injury. This figure here is a blood film that pathologists would be looking under the microscope that sees that essentially to orientate you. All these cells here that look like a donut, they are red blood cells. And this one little guy here is a bigger cell, and that's one of the white blood cells. But for this purposes, you can see a more normal looking red blood cell is this donut looking shape, because you would have learned in biology that red blood cells have this biconcave shape. But interspersed in between, you can see some of these that look alike but don't quite look as well-rounded. And they are essentially fragmented red blood cells, so red blood cells that have fragmented. And this is one of the features that the pathologists would be looking at under the microscope to help us make this diagnosis. And then, like how the previous speakers have already alluded to, in the context of complement-mediated atypical HUS, we've come to learn that in about 60% of patients, if we were to do their genetic testing, we can identify some form of an inherited variant, either in factor H, factor I, MCP, factor B, or C3, that predisposes them to developing this complement dysregulation, or an anti-factor H autoantibody that kind of impairs, I guess, the function of factor H and thus lead to the clinical phenotype of complement dysregulation. And so for patients who have undergone a kidney biopsy, this is kind of a representation of what the pathologist would usually see as well. To orientate you, this cartoon here is a cartoon of a nephron. So a nephron is the one single functional unit of our kidneys that does the filtering of our blood. And In the normal circumstances, we'll probably have about 1 or 2 million of this in our bodies, but this is about 1. So what they see is that the most characteristic finding is that they see presence of thrombi, so blood clots, in these very small blood vessels in the kidney. And then other signs that suggesting, so this leading to glomerular injury is that they see a shrunken sort of glomerulus, and they see further injury to the cell where you get lysing and damage of the mesangial cells. And then it's not in this slide, but you also see that hallmark injury to endothelial cells, which are cells that line our blood vessels. There might also be signs of more chronic damage, like kidney scarring due to the injury that occurs. And I'm sorry, I'm bringing this slide back up again, but I promise to keep it really simple. But I really think that this helps kind of build the story. So you've seen this before. This is the complement system. It's part of our immune system. Generally, it's a good thing. It's part of our immune system that helps protect us from invading pathogens. To simplify it, there are ways to cause activation, which then leads to activation of C3, which in itself can lead to an amplification loop. So basically, it's almost a self-fulfilling prophecy where it keeps activating itself if it's unregulated. And when that happens, it leads to activation of what we call the terminal complement pathway, which then leads to this formation of the membrane attack complex that causes the injury to the cells. This is constitutively active, so it's active all the time, active as I'm talking to you, so that we can react very quickly as soon as an invading bug gets into my body. But how we prevent that from activating on our own cells is that we have these regulatory mechanisms. So you would have heard about all this from the previous talks as well. Factor H being a very powerful regulator of an alternative complement pathway. Factor I, MCP, thrombomodulin being some of them. So what we've now understood much better is that in patients with complement-mediated atypical aHUS, in about 60-70% of the time, we can identify an abnormality that messes up with our body's ability to regulate this complement activation in our own body. And so it would make sense to think that, if you have a variant in factor B and C3, which are important components of this amplification loop, it could lead to the complement system being overactive. And or if you then have variants in these regulators, which prevents its job as a regulator, then you have failed regulation, which then leads to uncontrolled activation. And it is this process that, in atypical aHUS that occurs in our blood vessels that leads to complement-mediated injury of the cells lining our blood vessels, which is the endothelial cells. That then leads to a whole cascade that leads to platelet activation, forming clots around your blood vessel, which then, when the red blood cells try to traverse through, gets sheared off and lyses. It seems to affect our kidneys way more than it affects any other parts of our body. Like Christoph mentioned this morning, we don't completely understand why, but also to highlight that, patients with atypical aHUS, this can affect the blood cells lining other organs in the body. So patients can have symptoms that are related to that. So they can have CNS manifestations where you present with seizures. Patients could have, this kind of inflammation and injury to their hearts and to their lung vessels, which manifests with some of those symptoms as well. So this is something that we need to be mindful about. And then, taking you back again to the late 90s, early 2000s, when we did not have any anti-complement therapy, really any patient who presents with atypical aHUS, the management is supportive. And part of the treatment at the time that was thought to be potentially helpful was plasma therapy. And, the rationale, like Valentina built this morning, was that, the idea is that you have all this complement dysregulation and activation in your body. It's in your plasma layer of your blood cells. And so if we remove that plasma and replace it with fresh plasma, we are replacing some of that function. But like Valentina established, this is but a temporary measure because we're not dealing with the underlying problem that leads to this activation in the first place. And so it makes sense when we think about it. The historical outcomes, before we had anti-complement therapy was rather poor. Patients are at very high risk of, dying or progressing to kidney failure with their first presentation. And if they don't do that, there is a high risk of relapse, which leads to a chronic progressive course, which could lead to these bad outcomes. And, about in excess of 50% of patients, could develop permanent kidney damage, needing dialysis within 1 year of presenting. This is just a diagram taken from one of the studies which tried to assess that in a patient with factor H variant-associated atypical aHUS. And you can see this sort of basically suggesting that there are many, many relapses in the course of the disease within the first year of presentation. And then over time, we also did learn that, the severity of the manifestations, as well as, how likely things are to recur, seem to be influenced by sort of the underlying complement abnormality. So to, be very brief about this, patients with factor H variants and or variants in factor B of C3, which are those activating mutations, tend to follow a more severe relapsing recurring course, whereas there might be other mutations that might lead to a less severe form of manifestations. So then coming back to our first patient, if you remember, presented in 2004, so this was before anti-complement therapy, went on to plasma exchange for 15 months and went into remission for about 10 months, was able to come off plasma exchange, but then relapsed with a viral illness and had to basically be treated again with plasma exchange. And, at that time, for lack of any better treatment, this patient was maintained on regular monthly plasma exchange for 7 years. While this looks difficult and challenging in itself, I think if I added to it that this patient lived 3.5 hours away from the nearest pediatric center that was able to provide this. And so this patient had to travel as well, and how that would affect the quality of life and how they would feel and be able to manage. And eventually, the patient was identified to have an anti-factor H autoantibody that was contributing to this course, developed very mild chronic kidney disease, did not need dialysis, and was eventually transferred to adult care. In and around the time, I think there was the first reports that came out about the potential use and efficacy of an anti-complement therapy called eculizumab. And this was, I think, the first paper, if I'm not mistaken, by the German and Austrian group, which described 2 patients. I think this, again, was shown by Valentina in the presentation in the morning. So, the first patient was diagnosed with atypical aHUS and kidney failure at the age of 25, was discovered to have factor H variant, was on dialysis for 5 years, had the first transplant, lost that transplant within 5 weeks due to recurrence of atypical aHUS, and then had a subsequent transplant, which is what's depicted here. And despite a course of plasma therapy, the atypical aHUS worsened. And so at that point, the treating physicians decided to try a treatment with eculizumab, which was given here. And to orientate you, I think what it's showing is that the red line are the levels of platelets. So you can see when things were bad, the platelet count was low. And as things got better, the platelet count got better. The one in black is the creatinine. So that depicts your kidney function. The higher the creatinine, the worse the kidney function. So at the worst of the disease, the creatinine was high, but with response, it gradually got better. And this is heptoglobin, which is a marker of blood cell lysing. So again, suggesting that there was less blood cell lysing and suggesting effect of that one dose of eculizumab. Very similar in the second patient, diagnosed with atypical aHUS at 18 years of age, and the symptoms persisted despite being on plasma exchange therapy, and so they decided to try eculizumab and showed that there was clinical improvement after the one dose. And there were subsequent reports which eventually led to this landmark study that was published in 2013, which basically was a prospective study of a longer-term treatment of patients with atypical aHUS with eculizumab. What the study tried to look at was it looked at two main groups of patients. In trial one were, in a simplified way, you could think about them as patients who had a shorter, I guess, duration of illness, who were presenting, which were earlier in their course of treatment, so more acute and more active. Whereas patients in the second group were patients who've had this for longer, who were already potentially on plasma treatment, who may have developed longer-term injury. And what this study was able to show was that, in the patients who were more early in their course of disease, had significant improvement in their kidney function, as shown up here. But I think what was striking to me also is that in those patients who had a longer disease course, there was also some improvement in the kidney function. And yes, compared to the patients who were earlier in the course, that improvement wasn't as significant. But when you think about it, this is an improvement of about 10% of kidney function. That could be the difference between needing dialysis long-term versus coming off dialysis for a period of time. And that might lead to, better patient outcomes and quality of life. A subsequent follow-up study from that initial study only looked at 1 year outcomes. So this was the follow-up study that looked at the 2-year outcomes and essentially showed that there was sustained response at 2 years. And this two, I guess, landmark studies probably did a lot in advocating for this use and this treatment in patients with atypical aHUS. I think what this follow-up study also showed was that by measuring health-related quality of life, there was an appreciable improvement in how patients felt their quality of life were. They felt that with the treatment with eculizumab, they had improved quality of life. Okay. So moving on to a second patient. So this patient presented at the age of 9 months of age with some fever, vomiting, and upper respiratory tract symptoms. And again, had some blood in the urine and some protein in the urine. And again, had those similar features of TMA and aHUS. And on biopsy, also had TMA. This patient, this happened in the context of potential family history in that the mom had preeclampsia with the first pregnancy, which got better after delivery. But following this child's pregnancy, she developed severe preeclampsia, had to have emergency section again. But this time, her kidney function did not improve and continued to deteriorate. And the mom had to go on to long-term dialysis because she developed kidney failure. And when the doctors looked at her clinical signs, there were signs of this TMA as well as signs of TMA on biopsy. And so the patient that we were looking after underwent plasma exchange therapy, again, had to be maintained on long-term sort of plasma therapy at that time for up to about 3 years, but then relapsed while on plasma exchange therapy. And this was in the time when there was already access to eculizumab. And so this patient was started on eculizumab. And since starting eculizumab, at least at the last time that I was participating in the care, was about 3 years without any further relapses. This patient was, and the family and the mother was eventually identified to carry a hybrid genetic variant in factor H and one of the factor H related proteins that was likely the cause of the condition. But in our patient who then went on to eculizumab, she was vaccinated against meningitis C. Sorry.
In the previous patient, was there any correlation between the mother's complications of the preeclampsia and with the babies?
Yeah, so both, I guess, the mother and the baby carried the same genetic mutation. And in hindsight, I think they were both manifesting with the same TMA condition, atypical aHUS. So for the patient was vaccinated against meningitis C. At that time, the meningitis B vaccine was not available yet. And at that time, I guess the guidelines was not as strongly advocating for prophylactic antibiotics, so the patient wasn't on it. And while on eculizumab treatment, the patient developed an infection with meningitis B. And thankfully, it was detected very early, treated, and had full recovery without any bad effects. But I think this highlights the importance of up-to-date vaccination as much as possible against meningitis B. And now we have more vaccines against more subtypes of meningitis to be more protective, and also the importance of being on ongoing antibiotic prophylaxis to reduce the risk of catching meningitis. Okay, and so then moving on to the last patient is patient 3, who again presented at 2 years of age, which I think was addressing what your question earlier, had initially presented with diarrhea and had TMA. And actually from the diarrhea, we were able to isolate that the patient had an infection with this E. coli 0157, which produces the Shiga toxin. But what seems a bit different is that the recovery from the initial phase of the Shiga toxin aHUS was rather slow, but it did recover. But 2 weeks later, the patient again developed a relapse with an infection. And when that happened, the patient went on to plasma exchange, initially quite intensive, but over the course of 4 years, needed to be maintained on 2 to 3 times a week of treatment. And had over 500 episodes, 500 sessions of plasma exchange treatment in that period. And later on really developed this increasing dependence on regular plasma exchange and was developing frequent relapses. Unfortunately, the patient did progress to kidney failure and had to be on dialysis for that. And because of this course, this patient was investigated and was found to have a factor H genetic variant. And because the patient had developed kidney failure requiring dialysis, the question about transplantation came out and was being considered. Again, at that time, kidney transplantation was considered to be high risk for recurrence and losing the kidney transplant very quickly. And some of the potential workarounds to that is to consider a double liver and kidney transplant, which would be helpful for the disease, but associated with very high risk of bad outcomes, and which I would show shortly. And so in this patient at that time, the decision was to decide to wait on proceeding to transplantation. And this is informed by the fact that, in the pre-anti-complement therapy era, we knew that in kidney transplant alone, in the context of atypical aHUS, was associated with a high risk of recurrence, as well as a high risk of losing that kidney transplant. And again, in a similar way, how the disease course could be influenced by the underlying genetic variant. The risk of recurrence after kidney transplant was also stratified in terms of risk based on potentially the underlying genetic variant. Again, factor H and those activating C3 and factor B mutations being the ones with the highest risk compared to some other variants. And so, in that scenario, there was no effective treatment to prevent and or treat any recurrence post-transplant. Because of that, multiple different things were considered. In hindsight, you would have thought some of them didn't seem to have any real reason to work, and they didn't. Like removing the patient's own kidneys wouldn't have helped risk of recurrence. But some other approaches had some rationale, which some of the mechanisms we've come to learn of, like avoiding certain medications. If you remember the work that Christoph was showing, that with some of these medications we can identify that it does damage the endothelial cell layer, preventing factor H, which is normal, to do its job, and because of that, it might increase the risk of recurrence. And then despite plasma exchange, either as a preventative measure or treatment when there's a recurrence, the outcomes were variable, most of the time being not very effective. And so because of that, kidney transplant was almost considered a contraindication in patients who had atypical aHUS. And then we have this question about the combined liver kidney transplant. And it made sense because the complement proteins, many of them are produced in the liver, factor H produced in the liver, and so a liver transplant would cure that, and so a patient would have normal factor H. But to actually undergo the surgery to have a double liver and kidney transplant, it was associated with very high risk of death perioperatively. There were altogether probably about 30 cases that were known that underwent this treatment, but they were all collectively associated with very high risk of death around the time of surgery from infections. To provide a bit of a context, in the standard routine patient undergoing kidney transplant, the risk of death is probably less than 1%, and in this scenario, it's 14 times higher than that. And so for that reason, for our patient 3 that I just showed you, the decision was made to not proceed to transplantation at that time. And then again, as more and more information came out about the use of eculizumab, this was an additional patient by that same group that, again, highlighted that in a patient with atypical aHUS and factor H variant, the use of eculizumab could potentially be helpful in preventing disease recurrence and relapse, even after kidney transplant. So this patient had a kidney transplant from a deceased donor, did have 9 days of preventative plasma treatment, and then went on to eculizumab from day 10. And at the end of 1 year, there were no episodes of recurrence, and the kidney function was maintained, suggesting proof of concept that it was potentially a very helpful medication. And then as time went on, there were more and more evidence to suggest its efficacy both in patients without transplants as well as those with a transplant. This diagram I take from this French group, which reported this efficacy in eculizumab in preventing post-transplant recurrence. And yellow is kind of when the doses of eculizumab were given, and blue was plasma treatment. So when they looked at sort of their 9 patients that they treated, a few of them started the treatment prophylactically after some plasma exchange, while there was another group that initiated eculizumab before transplant and continued it after transplant. And then there was another group that basically initiated eculizumab at the time of transplant. And in all these patients, they were able to show that there were no recurrence after transplant. One patient unfortunately lost the kidney transplant, but it was not due to atypical aHUS. So, with more and more accumulated evidence with our patient, we were able to come back at the time to consider starting the patient on eculizumab therapy. And while it was not enough to rescue his own kidneys to make him come off dialysis, he was stable after a year of treatment, and he was placed on the transplant wait list, and several years later, successfully underwent a kidney transplant. And I could show this again because this is published in the media, and you could find this online. And really at that time, I think what was really inspiring was that we had a treatment that basically transformed the care of patients with this condition. And so thinking about sort of the question about preventing recurrences and graft loss for patients to undergo kidney transplant, there were further work that was looked at to try to build more and more evidence for this. And this study tried to look at the original prospective trials in patients who were sort of treated with eculizumab to evaluate this question. So when they look at it, to orientate you again, this is about 26, 27 patients. So each line is a patient. This thick black line here is the time of transplant and got the eculizumab treatment. This is the time of eculizumab treatment. And then those red dots that you see are actually transplants. So in these patients, you can see that before they started on eculizumab, many of them had had more than one kidney transplants because recurrence occurred and the graft had failed. But after they went on to eculizumab treatment, none of them developed any recurrence and maintained their graft at that time, adding, I guess, to the accumulating evidence that this is a helpful management in this context. And then when another group tried to look back at the global, the data from the global atypical aHUS registry, in a nutshell, basically what they were able to show was something very similar as in eculizumab helped enable patients to undergo transplant without recurrence and to help them keep their kidney transplants as healthy as possible, which then led to this consideration and almost expert consensus guidelines on how we would approach and think about getting patients with atypical aHUS through transplantation and try to stratify their risk to decide whether they need eculizumab or not. In a very simplified way, some patients who are considered to be high risk, so patients with factor H mutations, activating mutations with a history of recurrence would be considered high risk and would therefore need to be covered with preventative eculizumab. And then patients who might have low risk of recurrence, patients with MCP mutations or anti-factor H antibodies with very low titers and in disease remission may not need preventative eculizumab at the time of transplant. And then there's the moderate risk in between. By using this approach, a few years later, the French group published data to basically suggest that this approach works. So to show some highlights from this study, this again came from the French group and it's taken from a nationwide French registry. They very elegantly showed that, the risk of atypical aHUS post-transplant was consistent with this risk stratification approach, where you can see that patients who were considered high risk had more relapses if they were not treated. Patients who were moderate risk had moderate risk of recurrence. And then patients who were considered low risk had very little recurrence after transplant. And then what they went on to show was that in these high-risk patients, with this approach, patients who were treated with eculizumab, they were associated with less risk of recurrence compared to those who did not receive eculizumab. The study also showed that there's the risk of losing the kidney graft increased if there was atypical aHUS recurrence after transplant compared to if there was none. And then when they looked at how they had stratified the patients through their risk, either high risk, moderate risk, or low risk, so blue being receiving eculizumab and green being not receiving eculizumab, you could see that by using eculizumab in the high-risk patients, it led to much less recurrence compared to if no eculizumab was used, and that led to the patients maintaining their graft function and not losing graft function if they were not on eculizumab. This was very similar, but maybe less marked in those who were considered moderate risk. And then in those who were low risk, although they did not receive any eculizumab at the time of transplant, there was no episodes of recurrence. So suggesting that this approach works. And then in the question about, considering whether eculizumab can be discontinued or not, when they looked at the group that received eculizumab at the time of transplant moving forward, there were about 12 patients who discontinued treatment. So this asterisk depicts, all those patients and the times where they had withdrawn treatment with eculizumab. And what the group was able to show was that, recurrences happen in patients who withdrew treatment only if they were considered high risk. In the moderate risk group, they did not lead to any recurrence, suggesting that maybe there is a subgroup of patients who would do okay without long-term treatment. And then I think one of the more important findings of the study that highlighted, how the availability of a targeted treatment that targeted the underlying defect in complement really transformed care. So I hope with some of that patients that I introduced you to, it's clear that without treatment, the outcomes were very poor. These patients were considered non-transplantable and need to be on dialysis over the long term. But since the use of eculizumab, what this study showed was that, there were more patients who were able to keep function in their own native kidneys. So that is the purple line. So from the time around 2007, 2008 onwards, you can see that there were more patients who were maintaining their kidney function. And there were more patients in the red line that received kidney transplant. And that translated to the fact that there were then fewer patients with atypical aHUS who needed to be maintained on long-term dialysis, which is a good thing. And essentially showed that, this increased use in eculizumab increased the ability to transplant patients, and so it led to more patients who needed it being able to receive the transplant safely. And then this is my second last slide. Basically, more recent data, again, from a different group. This is the UK National Renal Complement Therapeutics Center, which is based in Newcastle, published their data, which also showed, improving outcomes for patients with atypical aHUS since the availability of this anti-complement therapy. Focus your attention to this graph. What they were able to show was that, the 5-year cumulative estimate of kidney failure-free survival. So basically, patients who were able to keep their own kidney function was higher in those who were treated with eculizumab versus historical controls that did not receive eculizumab. And then I think one last point from this was that even in their experience with withdrawal of eculizumab, they were able to show that there were a small group, well, not a small group, but a group of patients who potentially could withdraw treatment without any long-term consequences. And this was probably patients who did not carry any of this identified genetic variants, which I think this area of eculizumab withdrawal is emerging and I guess needs further investigations to really clearly identify how safe some patients can go without treatment. So I think sharing some of my concluding thoughts, I think complement-mediated atypical aHUS is a rare, ultra-rare disease that is associated with significant risk of mortality and long-term bad outcomes. And really, the advent of anti-complement treatment has transformed the cares and outcomes of patients with atypical aHUS and has made patients who were previously considered non-transplantable into transplantable patients. I hope this maybe paints a less bleak picture of the current state, but I think there's still a lot of work that needs to be done to continue to improve these outcomes for patients like all of you. Thank you.
What's the youngest patient you've seen to receive a kidney transplant?
So I think the youngest patient that we see is usually around 2 years of age, and it is usually due to the fact that we mostly get kidneys from adult donors, and so because of size, there needs to be enough space to surgically fit into a child, and we most of the time see that in that usually around 2 to 3 years old is when they grow enough for that to be able to fit into. So that's the youngest patients.
How do you do you pick the one that has the worst case scenario as the governing factor in terms of treatment and then transplantability and withdrawing treatment? I'm just curious, like, how do you decide which one you go with?
Yeah, I think as a general statement, that approach makes sense. But I think really it needs to be assessed based on the specific combination of mutation to be able to have a more informed, I guess, decision around that. But I think it would be a question of identifying the specific mutations.
Thank you for a great talk. I would like to ask you about the treatment duration in transplant patients. I know it's an unfair question since there is no final answer. It's an opinion that I'm asking you. With all this overview that you have presented, and that really illustrates progress and kind of, where the open questions are still as well. What do you think?
Yeah, so I think in my mind, based on the available evidence, I think it would suggest that in patients who were identified as high risk with factor H mutations, and especially if there's already a history of recurrence, I think I would be very reluctant to consider stopping treatment. But of course, in each individual situation, it could be assessed and informed by specific risk versus benefit ratios could be considered, but then it will require very close monitoring once withdrawal is done. I think what I didn't show was that I think in some of the studies, it also suggests that even in those who maybe weren't on treatment or who withdrew treatment, who then subsequently recurred, restarting treatment was helpful in, I guess, keeping things under control again. So whereas I think there is potentially a group of patients who are low risk, which could be considered for maybe an initial course of preventative treatment to cover them during the physiological stress of undergoing transplant surgery, getting lots of different medications to prevent rejection in the kidney, that could add, as in that concept that you showed about triggers in an underlying patient with underlying susceptibility, triggering relapses for a short period of time, and it could be 3 or 6 months, tie them over that period, and then consider withdrawing treatment.